Hi, everyone. Good morning, good afternoon, good evening from wherever you are. I'm Judy Cheng. I'm the Executive Director of the International Network of People Who Use Drugs. And on behalf of the Global HIV Prevention Coalition, UNODC, Input, and South to South Learning Exchange, I want to welcome everyone to the 11th Key Population Communities of Practice. Really appreciate the time people have taken today to join this webinar, especially towards the end of the year. And as you can see, the topic, and as you will have known, the topic is addressing risks of stimulant drug use amongst people who inject drugs. So whilst we acknowledge, of course, the use of stimulant drugs affects various members of key populations, this webinar focuses specifically on individuals who use and inject drugs. So I just wanted to take us over, the session objectives. So first, we really wanted to raise visibility, awareness, and understanding of stimulant use and its relation to HIV and other health outcomes. So those who know or work in harm reduction, which was the subject of a previous Communities of Practice webinar, we know that the package, or at least the three primary interventions that we're very familiar with, are mainly associated with opiate use. So needles and syringes, opiate agonist treatment, and naloxone. But we also know, of course, that stimulant use is increasing in many parts of the world, but our data and understanding of addressing stimulant use and appropriate interventions, have not really caught up with the rate or scale of use. So whilst people do inject stimulants, of course, such as cocaine and methamphetamine, many people also smoke and snort rather than inject, and of course also need equipment to use safely. And, we'll hear from others, but, generally there's a lack of, I guess, global kind of understanding or wide-scale understanding of or lack of evidence-based, substitution treatment for stimulant use. So there are, of course, various interventions which we'll hear about. So I think, it's really important to address in this webinar, and I'm really happy that we're having this webinar because, as we know with many things, lack of understanding about an issue and lack of knowledge about access or knowledge of the solid interventions to address an issue, does really drive fear and stigma. And this, is particularly the case around stimulant use. So, very excited today for the session. We'll be hearing from key figures in the field who will be sharing guidance and recommended best practices for addressing stimulant drug use. And we'll hear from, of course, leading global agencies on drug use on what is out there to guide programming. So the third objective is really to understand practical evidence-based harm reduction approaches for addressing stimulant use in various programming scenarios. So we will, later be introducing three presenters for this from civil society and communities that will be sharing practical experiences and strategies at both country and local levels to address stimulant use. They will provide learning on what, works in their contexts, share innovations in practice, but also demonstrate, probably how far we have to go in terms of really being able to scale these interventions up. And of course, importantly, we'll hear from the donor community and also hear their reflections on the response. So at the end and wrap up, we will look towards summarizing what we've heard and really be able to pull out and identify the collective actions, needed at either global, regional levels to be able to support national and local responses. So whether you're here as a community member, a policymaker, implemented donor, this is really a shared space for us to really come together and better understand how we can take action in the future to address emerging challenges in the HIV response in really thoughtful, community-centered, non-alarmist, and right-centered ways. So in the first section, we're moving towards a global overview, and really pleased to first introduce Monica Chapalger, who is the Global Thematic Lead for Drug Use and HIV at UNODC, who has 25 years plus experience in HIV prevention care for people who use drugs. So thanks, Monica. The floor is yours.
Thank you very much, Judy. So let's see my slides. Okay, so I'm going to talk today about UNODC work on addressing HIV and hepatitis with and for people who use stimulant drugs. Let's move to the next slide. UNODC, for UNODC work on HIV is mandated by our UNODC strategy, but also about international agreements like the outcome document of the UN General Assembly special session on drugs in 2016, and also because we are a member of one of the co-sponsors of the UNAIDS by the Global AIDS Strategy and the Political Declaration on Ending Inequalities and Getting on Track to End AIDS by 2030 from the General Assembly resolution that it's endorsing the Global AIDS Strategy. Next one. As I mentioned, we are co-sponsors of the UNAIDS. This year, we are proudly celebrating 25 years since we joined UNAIDS as the seventh co-sponsor with the mandate to work on HIV prevention, treatment, and care among people who use drugs. And then, and also 20 years since we are working on HIV in prison as part of the UNAIDS family. Next. I know that Annette will have more data in her slides, so I won't go to talk about those data. But I wanted to show you the recent distribution of the use of stimulant drugs in the world. This is from UNODC World Drug Report 2024, and you will see what are the regions and what substances are used in various regions of the world. Next slide. The health risks related to the use of stimulant drugs are, of course, the transmission of HIV, hepatitis B, and hepatitis C through the injecting route of transmission that increase the risk of bloodborne viruses comparing to injecting of opioids due to a higher frequency of injection, more frequent sharing, reusing of needles and syringing, sharing filters, mixer, and containers, but also the sexual route of transmission that might be particularly elevated among men who have sex with men, bisexual people, and those involved in chemsex. And another risk is the acute case of intoxication that present particularly challenging for first responders and emergency healthcare services. Next one, please. But few data about the HIV prevalence and injecting drug use prevalence. So also in the World Drug Report, it's showing a constant increase of people who inject drugs. You can see here the distribution on the map. And there is an estimation that there are around 13.9 people who are 13 million point 9 people who inject drugs globally. In the next slide, we'll see the prevalence of HIV among people who inject drugs. 1.6 million people are living with HIV, approximately 1 in 8. In the next slide, we are seeing the prevalence of hepatitis C among people who inject drugs. 6.8 million people globally, which is more than half of people who inject drugs. Next one. The Netherlands, I'm showing this slide, a couple of slides from the recent report on harm reduction, of global state of harm reduction. 93 countries are reporting having at least one needle and syringe program in this report that was recently released. And then, next slide, please. But only 11 countries are reporting needle and syringe program in prison. Next slide. The distribution of smoking kits, it's also quite low. Only 25 countries are reporting the distribution of smoking equipment. Next slide. There are major barriers in accessing harm reduction intervention for people who inject stimulant drugs, criminalization of people who use drugs, criminalization of possession or use are among them, stigma and discrimination, but also lack of policies and programs that can effectively increase access to harm reduction for people who use stimulant drugs. And of course, some other barriers are the law enforcement practices and high incarceration rate as a result. Next slide. So UNODC developed, I think 6 years ago, a technical guide on HIV and hepatitis prevention, treatment, care, and support among people who use stimulant drugs. We're very proud of this initiative because it was done with the support of our colleagues from a civil society group on drug use and HIV. A group of people with lived experience developed the first draft of this guide and, saw us through this process until we were ready to publish it. So this guide, it's describing a harm reduction package for people who use stimulant drugs. And this includes condoms and lubricants and safer sex programs, needle and syringe programs, and other commodities, HIV testing services, antiretroviral therapy, and is talking about the interaction between various stimulant substances. Can we go back to that slide? Can we go? Okay, yes, thank you. So it's talking about the interaction between various stimulant drugs and the antiretroviral medication. Then it's talking about evidence-based psychosocial interventions and drug dependence treatment, including is describing what was quite new at that time, the maintenance treatment in Czech Republic and in UK for people who use amphetamines. Now, although there is still, the treatment is still not approved, it's moving, it's expanding, and other countries like Ukraine are already implementing it. And then prevention, diagnosis, and treatment of sexual transmitted infections, hepatitis, and tuberculosis. Targeted information and education and prevention and management of overdose and acute intoxication, and is giving clear instructions on how to differentiate between the overdose with opioids and overdose with stimulant drugs. Now we can move to the next slide. And so based on this technical guide, we developed a capacity building program. The one who is the heart and soul and brain behind All this, the technical guide and the capacity building program is Matt Southwell, who is here in the call, and put a lot of time and effort to get this capacity building program right, and also traveled in many parts of the world to train people on how to address, how to implement harm reduction for people who use stimulant drugs. There are 3 modules, one on amphetamine and methamphetamine, one on crack cocaine and pasta coca, and one on new psychoactive substances, the injecting ones. Next slide, please. So the technical guide and the capacity building program is focusing on these 3 main substances because there is evidence that they are linked with the HIV and hepatitis, high rates of HIV and hepatitis transmission. If you remember the map that I showed at the beginning, there are many other stimulant drugs, but we are not focusing on those due to lack of evidence of link to HIV and hepatitis transmission. Next, please. I was reading before all the 8 interventions. When it comes to condoms, lubricants, and safer sex program, the recommendation is to provide pre-exposure prophylaxis, post-exposure prophylaxis where needed, condoms and lubricants, and needle and syringes. And of course, there are a lot of challenges that are linked with the provision of these services, but it's always important to have continued engagement with club owners and party organizers to target information campaigns through the apps on which people meet and plan for the chemsex parties, and to make the information available, and also condoms and needles through community-supported routes. Next slide. Is there any problem with the slides? Because I see some messages that people are not seeing something. I guess not, if it's silence. Let me know if you cannot see the slides.
It's clear, Monica.
Okay, good. Needle and syringe programs, they're different from the one for people who are using opioids. The times of the needle and syringe programs are different. The information on risk reduction and also the association with condom use are important. And it's always important to understand the context of drug use, the repeat and the rapid and repeat pattern of injecting stimulants, and the need to have enough injecting equipment. And also to know the stimulant using session can run for several days. Next slide. I got the message, Judy. I will finish in soon. So these are other paraphernalia that we are training people about. I won't read them, so I get to finish in 1 minute. Next slide, please. We also have a dedicated chapter on women, also in the book and in the training package. Next one. This is another activity that the project that we implemented, a need assessment studies for people who use new psychoactive substances in Moldova, Ukraine, Belarus, Kazakhstan, and Kyrgyzstan, and Uzbekistan. The publications are available on our website. They are in English if you are interested. And the last slide is that based on this assessment, we conducted an online web outreach project in Belarus, Moldova, Ukraine, and Uzbekistan that helped to reach very many people, of almost about 4,000 by online consultations and referral, and then send many people to get tested for HIV, hepatitis C, and sexual transmitted diseases. Identified, unfortunately, some people who were living with HIV or with hepatitis C or with sexual transmitted diseases. So that's what I wanted to let you know what we are doing, and please join us for the trainings when we come in your countries. Thank you.
Thank you so much, Monica, for providing a lot of the background and context and data, and also sharing some of the work that UNODC do as well. I think the global guide particularly is very important. So next speaker we have is Annette Verster. She's a social anthropologist who works at the World Health Organization, and she now leads the work on HIV, viral hepatitis, and STIs in key populations. And she'll be co-presenting with Dmitry Krupchenko. Thanks, Annette.
Thanks, Judy, and thank you, South to South Learning Network, for organizing this really important webinar, and for inviting us also to participate in this and speak. Next slide, please. Just to start with some data, which are also both from WHO Global Status Report and from the World Drug Report, UNODC, to refresh your knowledge around the fact that almost 300 million people use drugs in the year 2022, and about 20% of those can be classified as having a form of problematic use or drug use disorder. And 14 million people have injected drugs. We don't really know for sure how many have injected opioids or other substances, but overall, looking at use, the vast majority of people who used substances used cannabis, as you can see in the purple box, and followed by 60 million opioid users, and then the stimulant use, amphetamine, cocaine, and ecstasy. And just to put this in balance with illegal drugs such as alcohol, we know that almost half the global adult population used alcohol in 2019, and that 400 million people living with alcohol use disorder, which is around 7% of the adult population. Next slide, please. So this data comes from my colleague Dmitry Krupchenko from the Department of Mental Health and Substance Use. They looked at mortality and deaths attributable to drug use. And this was for the year 2019. And you can see that almost 600,000 people died of drug-related death in 2019. Almost 200,000 directly related to drug use disorders, and followed by actually a higher number of people died because of hepatitis C complications. So, and then HIV comes next, but you see that hepatitis is a much bigger burden in this population than other health issues, including HIV. And again, to compare this to alcohol death, so we said almost 600,000 drug-related, illegal drugs-related, 2.6 million deaths attributable to alcohol consumption. Next slide, please. Of course, we know that a lot of substances are used by the same people, and we always have to take the data with a pinch of salt. But again, I want to stress the size of the hepatitis epidemic being so much bigger than the HIV one, with almost 300 million between hepatitis B and C, compared to 40 million with people living with HIV. And for B, we know that it's preventable with the vaccine and that there's also long life treatment, while for hepatitis C, we actually have a cure. And Monica already also showed some data around the prevalence. So although maybe only 8.5% of the global hepatitis C prevalence is among people who inject drugs, if you look at just new infections, then it's between a quarter and a third of all new hepatitis C infections are attributable to injecting drug use, and a third also to death. So, and of course, there are other infectious diseases such as TB and latent TB infection. And then the next slide shows you also some information around sexually transmitted infections, because as you know, we have integrated HIV, hepatitis, and STIs into one area of work, one technical area of work, because of the overlap in epidemics, in populations at risk, and in responses needed. So here you see some data on various STIs, predominantly high prevalence rates among men who have sex with men, and sex workers. Next slide, please. So our work, therefore, as I said, focuses on integrating these three disease areas, and we developed new guidance in 2022, bringing the 5 key populations together, as well as the 3 disease areas and the whole continuum from prevention to diagnosis to treatment, with, of course, as WHO always has, a focus on harm reduction. Next slide, please. So what we did in these guidelines is that we developed a prioritized set of interventions, so a package of interventions which has a priority in them. And each key population has a different a specific package, but they're actually the same, more or less. Maybe the order is slightly different depending on the prevalence, the background prevalence of the specific disease areas. But the important part is that we prioritize between essential for impact enabling interventions and then essential for impact health interventions. And here the enabling interventions are prioritized in the sense that we realize that you can develop all kinds of responses with the health sector, but if you don't address the structural barriers of stigma, discrimination, violence, and in particular criminalization and punitive laws and practices, then it's very difficult for people to access these life-saving services. So these are therefore the enabling interventions, which include the decriminalization of drug use and possession. Next slide, please. And then, as I said, the essential for impact health interventions come next. And here you see that for people who inject drugs, harm reduction is the first and foremost intervention, followed by condoms and lubricants, which both are, of course, extremely relevant for people who use stimulants, as we have seen, and also by Monica's presentation. We defined harm reduction in this case as the combination of needle syringe provision, OAMT, the opioid agonist maintenance therapy, and community distribution of naloxone, which of course OAMT and naloxone are predominantly focusing on opioid use, whereas needle syringe programs are broader, and so are condoms and PrEP and PEP, etc. You also see that we have something on chemsex, and I'll come to that later. But it's clear that that package moves from prevention to diagnosis to treatment. So it's very straightforward, really. And then we have a third category of interventions, which are essential for broader health. So although they may not have a direct impact on the 3 disease areas, they're still critical to offer to people, such as in this case, for example, mental health, relevant also for people who use stimulants, and the screening and treatment of harmful alcohol and other substance use. So that's the package. Next slide, please. And just to say that we are continuing to look at the evidence and develop normative guidance where needed. And this is an example, the one on chemsex. So this is the actual good practice statement that is included in our 2022 guidance for key populations, where we have defined chemsex as when individuals engage in sexual activity while taking primarily stimulant drugs, typically involving multiple partners over a prolonged period of time. And we are actually working on extending this chemsex information into a policy brief with a little bit more background, with case examples, etc. So we hope to come out with something next year on this. Next slide, please. I don't know if Dimitri has joined, but yes, there he is. So just a final thing that also with regard to stimulant, wanted to mention that we're also in the development, in the process of developing or updating the needle and syringe program implementation tool that will come out next year, and working with Matt and other colleagues and Unitate colleagues on implementation of smoking kits for stimulant use. So thanks very much, Dimitri.
Thank you very much, Annette, and good morning, good afternoon to all participants. Thank you for organizing this webinar. So I would like to shortly also mention another WHO normative product, which is a guideline for mental, neurological, and substance use disorders, primarily in non-specialized health settings. But in some countries where specialized services are not really available, it's also used for capacity building in the specialized level. So these guidelines were initially started in 2008, and they regularly updated every 5 years. And last year we launched a new updated version. But it doesn't mean that the old recommendations are invalid, they just updated. But this time we have quite some attention to stimulants, and there's at least 5 recommendations you see on the screen, which deal with stimulant dependence. And specifically, it recommends the offering people with screening and brief intervention, and providing brief interventions if they're interested. And in case it's not enough, then also suggest referral for specialist level actions. And the other 3 recommendations, they're more specifically on treatment. One of them is actually on pharmacological treatment, which might be interesting. And I don't know if you have these discussions, but you might have seen a number of papers which are still exploring the possibilities of using different pharmacological agents for treatment of stimulant dependence, such as dexamphetamine, methylphenidate, modafinil, but there are many more like topiramate, even gabapentin. And so we looked at all of them during the last update. There was like an overall, I guess, 8 medication. And the guidelines development group considered that at this stage of the evidence development, and especially because these guidelines are for non-specialized healthcare settings, so that we are not yet at the stage of making positive recommendation, unfortunately. But we are hopeful that this will change in future. But at this stage, they actually are not recommended or even discouraged, especially for non-specialized healthcare settings. Therefore, probably at the moment, the main interventions that can be used for treatment of stimulant dependence, they remain to be psychosocial. And the most evidence we have are for contingency behavior, cognitive behavioral therapy, and contingency management, which show actually quite good effect size, even comparative to some pharmacological interventions. And so we think that, and these guidelines recommend that people should be offered these psychosocial interventions, but unfortunately, they are much less available than we would like them to be. And then finally, we have quite a new area which is addressed in these guidelines update and not before on recovery-oriented services, but again, stressing here voluntary basis and at least some of them which shows most promising results, and such as case management, long-term residential and continuity community care approaches, occupation-based therapies, and of course, peer support groups. So now these guidelines are out. Last year, as I said, now we are working on operationalizing them into intervention guides where clinicians or healthcare practitioners will have more instructions how to implement them. So thank you for your attention. We might have taken a bit more time than we were expected. Sorry for that. But once again, thank you and all the best.
Thank you, Dimitri. So now we're moving over to the implementation practice and learning from civil society and their sharing of practical experience. So yeah, really pleased to introduce Yolande Andrews, who's the program manager for human rights and key populations at NACOSA from South Africa.
Oh, thank you so much for having me. I think the presentation has been shown. So Program Manager for Human Rights and Key Populations under the Global Fund grant. We can move to the next slide. There we go. So I am aware of the limitations in time. So I do apologize if I'm going through this very fast, but you are welcome to reach out if you want to know a little bit more about our program. So under the Global Fund grant, it is quite a clinical program in the case of HIV services as well as harm reduction packs. We also provide opiate substitution therapy and also hepatitis C and B testing and treatment services. The program does focus on opiate users and particularly injectors. So we have about 15,586 injectors in our program, but we also have approximately 3,000 opiate smokers in the program. However, in our WU Assist that is done with our opiate substitution therapy patients, as well as our outreach forms and risk assessments, we are fully aware that a lot of our clients are polysubstance users and are therefore using stimulants. And therefore, we've had some opportunities to adjust our programs so that we can accommodate the needs of stimulant users, although we do not provide substitution therapy for stimulant users as yet. What is key, though, in our program is obviously the psychosocial support and behavioral change interventions, looking at groups like contemplation groups, groups specifically for women who use drugs, and then also our treatment adherence groups. None of this, though, is possible unless we continue to advocate. So key focus of our programs is what is our advocacy role and messaging around substance use and harm reduction services, not only for opiate users, but also for stimulant users. We may move over to the next slide. So, the particular reasons why we are focused on stimulant users or our polysubstance users, because we understand that with stimulant use, they are incredibly high risk. And so one of the key focuses is reducing health risks of those that are sharing smoking supplies. Particularly, this is relevant for South Africa because we do have an incredibly high TB prevalence in the country. So it is critical that we look at commodities that minimizes the risk of sharing. This is also relevant during our time of COVID in this country as well, where we looked at, safe smoking packs. And then also it's about, providing more autonomy to those that are using substances as opposed to only be able to provide harm reduction packs for injectors. We also want to minimize as much as possible the risk of injecting. So our focus is on those that are stimulant smokers, is to be able to provide them, safe smoking packs so that they do not transition over to injecting. But critical component is obviously educating them around the risks, the increased risk of injecting, and also being able to monitor their dosage as they're currently doing. I think the last one is that it also is important for us to be able to expand our engagements with people who use drugs. And so a lot of our discussions around stimulant use and the availability of safe smoking packs allows us an opportunity to engage them around their use, but also around their need to access other services like psychosocial support, and then also economic empowerment interventions. We may move over to the next slide. And the next slide will particularly show you one of the safe smoking packs that we have. It is something that we engaged, stakeholders, particularly also the South African network of people who use drugs in South Africa, around, what should be the commodities added. I want to express, though, that this is not the ideal safe smoking pack. The reality is for, those that are using stimulants, you really need to be looking at the use or the provision of pipes as well as bulbs for those that are using meth. The fact is, though, it is quite difficult to get that over the line in South Africa in terms of the provision of that, but it's something that we've looked at, and we've also looked at the costing around it. This safe smoking pack, though, is in terms of the provision of a mouthpiece that they can attach to the pipes that they are currently using, looking at aluminum foil, Rizzlers, and particularly the thought of cracks in their lips that could also result in sores and the increased risk of transmission if sharing, any smoking apparatus. And then obviously there is the idea that, infection control through the supply of alcohol swabs. Alongside the safe smoking packs, it's also critical for us to share, our overdose management, IC materials, our harm reduction, IC materials. And for those that are also smoking while injecting, we also have, IC materials around safe injecting practices. The next slide that will be shown is actually just an indication of why this is particular. So if we can move over to the next one, fantastic. So the next slide just gives you a particular reason about why the commodities that you find in the safe smoking packs are provided, and you're welcome to review that. What we do want to see, though, is a little bit more of an evaluation of what, safe smoking packs helps to reduce infection of HIV and hepatitis, particularly with hepatitis C being, quite easy to transmit when sharing apparatus. The question about hepatitis C in South Africa is even more important, as we have an 83% hepatitis C prevalence that we've noted in our opioid substitution therapy patients that have been screened and confirmed hepatitis C positive. And we also have a 21.8% HIV prevalence amongst those that are injecting. So those that are polysubstance users with stimulants, it is critical that we look at what type of safe smoking packs is necessary for them. Next slide. So I think this is particularly interesting in terms of what information is available in the country to actually advocate for certain interventions as well as policy reform. In South Africa, it is unfortunate that we do not have substantial overdose incidence data in the country. We do have the Secunda reports, which provides community organization as well as rehabilitation information around overdose, but it's relatively limited compared to the actual amounts that are being reached. NACOSA, particularly when we were looking at an overdose kit or overdose prevention or management strategy, we wanted to gather sufficient data to advocate and justify this. And so we did a survey that could be done on the phone with the beneficiaries or the patients. It was approximately 25 questions. We did within 8 districts, 8 cities that we operate in, from the 4th of July to the 12th of July. And 1,037 respondents, with 84% of them being male, which is not uncommon in our program. But also what is clear is that when you are dealing with stimulant users or any substance users, including opiate users, is to recognize the socioeconomic circumstances when trying to distribute commodities. And it was worrying that 64% of them were unhoused, or as one would refer to as homeless. What was good or interesting and not unexpected was that 66% of those that were surveyed indicated that they used multiple drugs. So 793 confirmed opiate use, 329 confirmed crystal meth use, 201 confirmed mandrax, and then 103 confirmed using rock. 72%, interestingly enough, indicated that they had never experienced an overdose. But those that did experience an overdose, 96% reported having experienced an opiate drug-related one, and 33% reported having experienced a stimulant drug-related overdose. Of those that experienced an overdose, 84% reported accidental overdose, but 30% actually indicated there was an intentional overdose. Once again, making it very clear that we need to prioritize psychosocial services and mental health services in response to this. 55% indicated they witnessed or knew of someone who overdosed, and the 72% of those that indicated they knew of someone reported that that person had experienced a fatal overdose. These overdoses primarily happened during the day, but a large amount happened at night or in early mornings when no emergency services were particularly available. And 45% of them said that, help was not particularly available. And 55%, though, had also indicated that they were not sure of how to manage or treat an overdose if they experienced it or saw someone else. This highlights the need for increased education around overdose prevention and overdose prevention and management. Next slide. So just to articulate some of the work that we've been doing or been involved in looking at, intersectionality amongst people who use drugs, particularly MSM, sex workers, is also to look at, chemsex guidelines, because we do know that a lot of chemsex users are particularly using stimulants during their interactions, and particularly a large portion of them are starting to trend towards injecting of stimulants. So NACOSA is currently a member of the Chemsex Guidelines Committee that is supported by the World Health Organization. We have particularly submitted harm reduction considerations for young chemsex users, post-violence care support for chemsex users, and overdose management for chemsex users to be included in the Southern African HIV Clinician Society guidelines for harm reduction. In March 2024, we received training on sexualized drug use from UNODC, as well as we've received training from our partners, Out Wellbeing. We've also worked with Out as well as Sanput around particular indicators on stimulant use to be included in the Sekindu report under the Medical Research Council. And we've also developed particular harm reduction IC materials around stimulant use and chemsex. Next slide, which will be my last slide. I do want to articulate that if it wasn't for the partners that we have, as well as for our funder, a lot of the innovations that you see here would not be possible. We've worked with Sanput to strengthen the contemplation group facilitation materials, particularly for people who use drugs, which include stimulant users. We've also, since May 2023, have funded the virtual OST ward rounds that is providing clinicians and OST nurses support and an opportunity to learn from each other, both local and international experts around opiate substitution therapy, hepatitis, as well as challenges around polysubstance use. We have worked with Clowns Without Borders around Simbosani, a parenting program that equips people or parents who use drugs with parenting skills. We've worked with Bridges of Hope around a facilitation tool for young people who use drugs to better understand life changes, life goals, as well as the substance use types and the risk. And lastly, we are currently, based on the results from the overdose incident survey, are launching an overdose kit from the 1st of December in Nelson Mandela Bay and Umgungundlovu in South Africa with 100 service users, where it is kit specific for stimulant related overdose, as well as for opiate related overdose that includes naloxone. And once again, just an opportunity to thank those that invited us to present on our program, and once again an appreciation for our partners as well as Global Fund for allowing us to advocate around this. Thank you so much.
Thank you so much. And yes, just for showing the wealth of kind of services and programs that NACOSA delivers. It's very impressive. So next speaker, we have Angela Wirtz from Mainline. I've worked with Angela for a long time, but I don't know if I'll ever get the pronunciation of her last name correct. Angela is head of knowledge, learning and partnerships team and has been working in the field for 20 years. Yeah, And Shelley, you have the floor. Thank you so much for joining.
Thank you, Judy. And yeah, it is very Dutch. It's Ancella Voets, actually, my name. But that's okay. Thanks a lot. And thanks for inviting us and having me for this presentation. So I work for Mainline, a harm reduction NGO in Amsterdam, where, as well, in the rest of the Netherlands also, crack cocaine has been the drug of choice for like since 20 years ago. So we have a lot of domestic experience working in stimulant harm reduction, but also, and that's more what I will talking about today, international experience working with partners on stimulant harm reduction. So next slide, please. We've done some research in 2018 and we came up with 12 strategies to address stimulant harm reduction. And though 2018 seems a long time ago, stimulant use has only increased since then. So this is, I think, still an increasingly important and relevant. Next slide, please. We have included in our research, first of all, a literature study in 3 languages, in English, Portuguese, and Spanish. And then we documented and analyzed 7 interventions targeting people who use stimulant drugs in Canada, in Brazil, in Uruguay, South Africa, Indonesia, Spain, and the Netherlands. And based on all this work, we wrote this guidance document, which is called Speed Limits, to help people implementing and designing interventions for people who use stimulants. Next one, please. So I will try to go through the 12 interventions that we found. The first one is safer smoking kits, and since Yolande talked about this quite extensively, I will not go into this. You will see with each intervention some examples. The ones that are underlined are described in the report, so in this case, Counterfeit from Canada. But as you heard, NACOSA in South Africa has also done great work in this, so we have also added examples later on that are not fully described in the report. The second one is prevention of sexual risks, and you've heard a lot about this also already, because this has been part of the harm reduction package for a long time, except that we also want to go beyond HIV and other infections. And in this area, we would specifically also want to focus on safety and well-being, on addressing sexual violence, abuse, and also staying in control in sexual relationships. So here you see examples from Brazil and from Out Wellbeing, also already mentioned in South Africa, who does particular work on chemsex, while Escola Libre is working more with street-based sex workers who use stimulants. Then the third one is female-focused interventions. There is evidence that women who use drugs, and especially women who use stimulants, are exposed to additional harms as compared to men. So it is important for them to also access care, specifically to have access to pregnancy and parenting care, and to have access to sexual and reproductive health and rights, including not only gynecological care, for example, but also childcare, family support, and very importantly, also legislation that does not take away their children because of their drug use. And when we talk about female-focused interventions, it's also important not to focus only on the women, but also on their partners. Next slide, please. The fourth intervention that we described are drug consumption rooms. Traditionally, addressing opioid use, drug consumption rooms are also important for people who use stimulants as a safe place where use can take place, to reduce public drug use, to also serve as an entry point for people into other healthcare. And here the example is from the Netherlands, from the Regenboog Group, who is managing quite a number of drug consumption rooms in Amsterdam. Self-regulation, I think, is a very important one that people who use stimulants can actually have in their own hands. So this is more about how to work with people, train them, and support them in regulating their drug use, because opposed to opioids, people who use stimulants, they can go on for days and nights without eating, without sleeping. which obviously is not very well for their physical or their mental health. Here, both examples come from South Africa and are mostly looking at contemplation groups that were also described by Yolan. Other things in this, other interventions in this category would be meditation, for example, mindfulness. And in the Netherlands, we've done a lot of work around self-regulation through games, trying to trigger and to train people and to find ways with them on how to regulate their drugs. For example, don't use alone, don't use when you're not feeling well, eat before you use, and those kinds of simple tips and tricks. Then the next one is about housing. Often we see that people are requested to enter treatment before they have the right to a house or a shelter. But there is evidence that turning this around and offering people who are street-based safe housing first does actually help them to reduce and regulate their drug use. Both examples here are from Brazil. And in both cases, as well as Attitude as Braços Abertos, they saw a reduction of uncontrolled drug use among the participants after supporting them in finding stable housing. Next one, please. Substitution is the seventh intervention that we found. And as Dimitri already mentioned earlier, there is not enough evidence for this one yet, though there is some evidence suggesting that dexamphetamine may be effective for people who use crack cocaine, and the Ritalin may be useful for people who use amphetamines, but still much more evidence is needed. Maybe interesting, the example that I am mentioning here is that the Amsterdam municipality is planning to do a pilot with cocaine substitution. It's really substituting illegal cocaine with legal cocaine. That would be in a similar way as heroin programs that already exist in the Netherlands and some other countries. So we're hoping to start that soon and also get some evidence from that. Then the next one is peer-led outreach interventions. I don't think we need to say much about this because this is also an intervention that is already well known, and also the effects and the importance of it are well known. Having peers working in outreach actually increases the reach of people who use drugs, increases the acceptance of the program, also increases the authenticity of the program when it's easier to base it on the needs of people who use drugs. With an example here from Charisma, who is doing very good work with people who use shabu, which is another name for methamphetamines in Indonesia. Then drop-in centers, also not a new intervention, but also very important for people who use stimulants. Again, to offer a safe place where they can relax, where they can calm down, where they can eat, take care of their hygiene, get maybe some sleep, and also receive some counseling that can also help them accessing other services. So I don't think we need to say more about this. Here we see an example from Uruguay that is also in the report. Then number 10 is drug checking. Next slide, please. Which is mostly done in nightlife settings, where people can voluntarily and safely hand in their drugs for testing, so that they can actually know what they are taking. Because obviously, since drugs are illegal, there is no quality control. So this helps people to find out if what they are buying is actually what they're hoping to get. And we do see a proof that people, when it's not what they're expecting, if there is another drug in there or another agent, people tend to not take it, which of course helps their safety. Then there's online interventions, a very cost-effective way for support that can be with or without contact of a professional. It can also be self-guided online, as long as people do have access, of course, to the internet. There is strong evidence that online interventions are supportive and helpful for a variety of mental health issues, and also for the control of or the reduction of alcohol use. We still need some more evidence for this intervention for people who use drugs. But a good example here comes from CampSafe in Spain, and here it is blue because there's actually a link to their website when you click on it. But it does help in combination with other therapeutic interventions, and therapeutic interventions are at the same time the last one of the interventions that I want to present to you, which can be done either by specialized healthcare providers, but also by trained non-health professionals who can do simple interventions such as motivational interviewing and others. And this has proven to be effective to support people committing to change, again, increasing their adherence to treatment and reducing drug-related harms. So these are the interventions I wanted to present. Then finally, I have some, on the next slide, some general advices maybe that are also all presented in the report on what to think of when implementing harm reduction for people who use stimulants. So I invite you to have a look at the report to get more details on all this. Then there is one more slide on the mainline approach on how we usually prefer to work with people across the world and with organizations. So developing interventions with peers and with harm reduction implementers on the ground, then train people and then support them in the service delivery and guide them to put what they have learned into practice. And then finally, on the last slide, there are some links to the report, the speed limit report, and also to our general website, to our ChemSex website, and to our harm reduction school, where you can find online courses also on mental health and stimulant use. Thank you very much.
Thank you so much for taking us through the speed limits report. I believe it was the first civil society reports on addressing stimulant use amongst people who use drugs. So thanks for that. And I think it's really important to have gone through housing as harm reduction and drug consumption rooms as well, and peer-led interventions. So thank you, Angela. So next speaker, we have Matt Southwell, speaking of peer-led interventions. So Matt Southwell is Managing and Technical Director of COACT, a community-led technical support agency. And as you would have heard before from Monica, he also worked on the UNODC, WHO, UNAIDS technical guide on stimulants also. So Matt, the floor is yours. Sorry, we're running a bit out of time. So just please be mindful of that. Thank you.
Okay, thank you very much. So I've just got some slides from the UNODC training course, just as a backdrop to some comments that I wanted to make. I'm particularly glad that Monica didn't go into detail about this slide as my starting one. So I just wanted to, within the UNODC guidelines, UNAIDS, WHO guidelines on HIV prevention, treatment, care and support with people who use stimulant drugs, there is a whole range of interventions being recommended, and I think it's understanding this range of harm reduction tools as a key engagement process. I think we've seen the huge vulnerability when we have inadequate coverage of needle and syringe programs. It's often among people who use stimulants or people who inject stimulants that we see the exposure of those limitations. So we've seen HIV outbreaks among people who inject drugs in Glasgow, and again in Glasgow in Scotland in 2015. Also among cathinone, which was linked to cocaine injection, and then similarly in Romania linked to cathinone injection or methadone injection. So we have this pattern whereby the rapid, repeated and social patterns of cocaine injection make people who inject stimulants very vulnerable when there are not adequate access to needles and syringes. The patterns of using outside the traditional opening hours, and then also the sort of patterns of using over several days and often in groups. So that's, I think, a key challenge is how do we get needles and syringes out there in sufficient numbers. EuroEMPA, the European Network of People Who Use Drugs, has recently published a technical briefing on peer-to-peer needle and syringe programs, And I think peer-to-peer needle and syringe programs are particularly effective at getting needles and syringes out into the spaces where people inject drugs, and particularly among parts of the community that may not more traditionally use sort of fixed site needle and syringe programs. We can also see that the distribution, the use of stimulant pipes, particularly sort of Pyrex pipes, which are more robust and heat resistant, particularly with crack stems coming with different gauzes, and then with the sort of more bold pipes for people using meth. I think the key thing that we've been learning about the development of needle and syringe availability through the UNITAID study is the need to do values and preferences work, really asking people who inject drugs on the ground what needles and syringes they want. So yes, pushing towards low dead space needles and syringes as the latest technology, but really having a dialogue with people who inject drugs about exactly what equipment they need on the ground to help them apply harm reduction. And the same applies to stimulant pipes as well. Now, yes, there are some sort of broad principles of which pipes are used with different drugs, but that will, preferences vary from country to country. Smoking patterns vary from country to country. So, we're finding in the UK that people want to smoke with a very big flame, which requires different filters from patterns of smoking in Canada, for example. So that's why we need to have dialogue with people on the ground so that we make sure we provide the most appropriate pipes. For example, working recently in Pakistan, talking to partners on the ground there, where people are smoking methamphetamine in water bottles, drawing up smoke from a piece of a light bulb fitting that goes through a plastic tube. Now, the principles of using those types of pipes as an engagement tool to bring people into service remains the same, but we need to understand how to. Sorry, I can't read what you're saying to me on it. What you're asking me to do. So I see you writing it. Okay, so when the slides move, sorry, apologies. Yeah, so I think that's the key shift, which is we need this values and preferences work. We've seen similar work being done by Charisma with foil in with the support of Mainline, in fact, in Jakarta. So let's move to the next slide. So that's the background. I think understanding harm reduction. Now, this is a backdrop of harm reduction advice that we've drawn out through our work through the stimulant health checks that we've developed with core harm reduction advice. But again, we need to tailor advice particularly to the context that people are using in, and work with local community partners to understand how global sets of guidelines, gathered information that we gather from the grassroots can then be best transmitted and shared out through people who use drugs, thinking about the different routes that people are using by. One of the important things that's coming out of the SIP study, the Safe Inhalation Pipe Provision Study, being led by Professor Magdalena Harris at the London School of Hygiene and Tropical Medicine. Now, the results from that study are really clear. We're starting to see people reducing their sharing of pipes, reducing their use of homemade pipes, reducing their use of pipes with harmful cigarette ash, and also significantly for HIV and Hep C prevention, also people are using pipes as part of route transition. So significant numbers of people choosing to use pipes to switch away from the rapid repeated patterns of injecting that can cause problems around stimulant use, or just giving people options at times as well. So it's not always a complete switch. It can just give people that capacity to prioritize harm reduction, I should say. And I think that, but what we know about stimulant pipes is that their key function is that they become a hook to engage people in services. We've seen patterns at the Den Soluk Nauru project in Kyrgyzstan, where web-based outreach and stimulant pipe distribution has been used to draw people into HIV testing. We're considering doing something similar through the UNITAID project to look at whether we can engage people in hepatitis C testing. So that, yeah, that becomes, I think, starting to use these tools, potentially for harm reduction benefits, but also seeing them as key ways to engage populations who currently often sit outside services. Let's go to the next slide. And I think, again, the points that Ancella was making about self-control, when you're using stimulants, you're looking to use techniques and strategies that help you self-regulate. Definitely when I first learned to smoke cocaine, actually in the Netherlands, working with Dutch Surinamese users, they helped me learn a pattern of using that was about balancing uppers and downers to regulate control. And then my last slide. I think communities are key to getting people to engage. So I think, if you go to my next slide, the key point about stimulants is that stimulants are used by very diverse populations. So we know what interventions we want to use, but it's only by working with communities that we're going to be able to reach out and properly get those interventions to connect with people and then draw them into services. Thank you.
Thank you so much, Matt, and thanks for all the work that you do as well. So next we have Nang Peng Aikam, who's the coordinator of Drug Policy Advocacy Group Myanmar. She has extensive experience and expertise in public health harm reduction and drug policy, particularly in Myanmar and Southeast Asia.
So thank you, Judy. Yes, so hi, my name is Ban Yi, and then I work for the DPAG in Myanmar. And today I would like to present about the stimulant drug use and some harm reduction self-regulation methods in Myanmar. Next slide, please. So for those, who may not have heard about Myanmar, we are based in Southeast Asia, and then we are bordering with China, Laos, Thailand, and then in the west with India and Bangladesh. So we are also in the famous Golden Triangle region. And we have been facing a long-standing internal conflict. And then since then, the military has played a dominant role. And most recently, in February 2021, the military seized power again, and we are still under the armed conflict. Next slide, please. And in terms of drugs, in the production stage, we are actually the world's largest producer of opium and also a major producer of amphetamine-type stimulants, particularly methamphetamine pills and crystal meth in the region and also in the world. Next slide, please. If you look at the drug consumption sectors, so we have a long-standing opioids issues. Actually, history of heroin use, mostly in the northern parts of Myanmar, and then also the eastern and western part. So the transmission of HIV among people who inject drugs is pretty high, with a prevalence of 35%. So because of sharing of unclean needles and syringes, and the prevalence of hepatitis C is even higher with 56%. And when we look at the trends of drugs use, even though the heroin and opium use has been higher use, but in the recent years, the use of methamphetamine has been increased. Next slide, please. So let's have a look at the stimulant drug use in Myanmar. So the most common is methamphetamine tablets. So it's called WY, Yama, or Ati, or fruits in local language. And nowadays, crystal methamphetamine is also increased, which is called ice or YK in local language. So regarding the tablets, a great diversity of people are using them, although the pattern of use very significantly. So most common usages among youths for social practice, and then including teenagers are using them. So work-related use is commonly seen among people working at night. So those who are working at nightclubs, bars, and karaoke bars, and among the female sex workers and their clients. Also, it was used by people who are engaging in difficult manual tasks, such as jade and gold mining, and long-distance truck drivers and night drivers. And in the South, rubber tapping and people who work on boats in the fishing sectors, and migrant workers in agricultural jobs. And nowadays, in the major cities and urban areas, so among youths, it's been popular for fun, particularly ice and other stimulants such as ketamine, ecstasy, and happy water. Next slide, please.
Enough time.
So this is quotes from the responses from the community research that we have been conducted in 2019 and 2014. So some respondents said actually methamphetamine has been used in various works of life, and then some enjoy using by staying at home, while others play music and sing. Wealthy people, artists, football players, and even some police officers like using methamphetamines. Also, here is another quote from Yangon, where we are based, and one Yama tablet costs only 1,000 kyat, so it's less than a quarter of a US dollar. And why the use of methamphetamine is increasing? Because it's easily accessible and widely available nowadays. And when people are stressed out or not in a good mood, they will be suggested to try this and that, and then they will use it as an outlet of stress or yes, from depression. And then and even children around the age of 10 to 13 years old are using it already. Next slide, please. And this is how people commonly use methamphetamine. So here are the WY pills, and then they put it in a foil and then smoke it through a water pipe through this plastic water bottle. So these materials are like recycle materials, and then from the bottom of the vial they just burn it with a special lighter, and then also they smoke it, and then some people inhale it directly, like chasing the dragon style. Next slide, please.
Okay. 5 minutes left.
And then this is the respondents from the use of ice or the use of ice. So in Yangon, it's nowadays people from the nightclubs or karaoke, they like to use it, but they don't inject ice, they just snort it. And additionally, they use it with 2 or 3 other drugs, such as heroin and yama. And sometimes when we gather, we use drugs for sexual purposes, but for recreational purposes. And then, yeah. And then some are using it together with other drugs, such as heroin. And then also in queer or MSM communities nowadays, it is also very common. So they actually dissolve it in water and inject it, and to enhance sexual pleasure, and then to focus more on sexual activity and to reduce pain. So yeah, I have a few more slides, so I will go a bit further. Next slide, please.
Yeah, go through them quickly.
Yeah.
Thank you so much.
So actually, yeah, the risk is are high, and then the barriers in Myanmar are very high also, and there is stigma and discrimination and the fear of being arrested, and then we have very limited harm reduction services and evidence-based treatment and information, and the limitation of data is also a strong barrier. And my last slide. Next slide, please. And we have the harm reduction tips by people who use stimulants. So during our community research, this is actually the recommendations that they provided. It's actually a wide range of recommendations, but I've taken a few. And then some are actually similar to the ones suggested by previous speakers. So setting one's limits and deciding the number of tablets one would take, and then taking breaks from time to time, and then to have a proper sleep and also eat a full nutritious food. So to keep off the dental hygiene, and then also use a filter when smoking. So when you are in a bad mood or angry, don't use methamphetamine, and do not panic if you are having bad experiences. And I like this one because it says that when you are pregnant, take a break at least during your pregnancy. And if you are trying to stop or reduce your meth use some cannabis or kratom. So it's like a local plant-based substance which can relieve your withdrawal symptoms. So it's actually very helpful that they provide these kind of tips in a resource-limited setting. This is yes.
Thank you. I think it was, a great way to end as well on really useful tips from the community. Thank you.
Thank
So
you.
before we
Thank you
move
very
on
much.
to the donor segment, just want to remind people we didn't have time for the Mentimeter, but if you have Q&A questions for the presenters, please just use the Q&A chat function, the Q&A box. So next, really pleased to introduce Thomas Brigden, who's a portfolio lead for people who use drugs at the Elton John AIDS Foundation. Thomas, you have the floor. Thank you.
Thanks so much, Judy. I hope everybody can hear me okay. And yeah, really appreciate being asked to join this really important session today. Okay, we can go to the next slide, please. Thank you. So a little bit about the foundation and what we fund. Our strategy for people who use drugs has three overarching goal areas. The first is around reducing the criminalization of people who use drugs and addressing legal and policy barriers. The second is around generating more support and resources for harm reduction globally, particularly in lower and middle income countries. But the third area of our strategy, most relevant for today, is really about responding to the changing trends and dynamics in drug use globally, obviously with a clear line of sight to HIV, but really being responsive and listening to how people are using drugs and any emerging risk areas. Next slide, please. So we've always supported work for people who use drugs since we began as a foundation in the early 90s, and they continue to be a really key part of our current strategy. In that current strategy, we've expanded out to also include people who use drugs, as I said, recognizing that different dynamics are at play globally. This flexibility that we have as a private foundation means we can fund new models, pilot programs, testing out theories of change that partners have, and looking to put together new concepts. And we're also looking beyond HIV as just the entry point. So as others have mentioned, really well in the session today, how provision of services for stimulant use can bring in people not reached by more opioid-focused interventions, which presents another opportunity to offer additional support. And of course, we're looking at themes that intersect. So a lot of our work across our portfolios, not just for people who use drugs, are also looking at sexualized substance use and mental health. So they're becoming a really core part of our programming for key populations. Next slide, please. Thanks. So all of the work that I'm going to present is from our partners who are incredible. We don't do any implementation as a foundation, so everything is down to them. Some of the work we're supporting in South Africa is really intended to build out a holistic model for HIV positive men who have sex with men who are engaging in chemsex. We're seeing really high HIV prevalence within this community, but our fantastic partners out LGBT are putting together a really comprehensive model that provides individualized care plans, taking into account mental health, employment, skills building, harm reduction, stimulant use, and is having really great results so far in retaining people in ART. Next slide, please. In the US context, we've got two programs at the moment, both reaching people who use stimulants. One is around increasing education and demand for naloxone and overdose prevention commodities. But as we know in the US, people who use drugs, people who use stimulant drugs rather, are also being affected by the opioid overdose crisis because fentanyl is showing up in other drugs in the drug supply. So this is also protecting people who use stimulants from accidental fatal overdose. We're also working with organizations who distribute harm reduction supplies across the US and have supporting them to come up with a model and a system to sustain the distribution of safer smoking supplies and harm reduction commodities for people who use stimulants. So trying to put in a sustainable system for unfundable supplies. Next slide, please. And just a note as well, we're also working with people who use stimulants in East Africa and in Central Asia. One project working with young people who use stimulants in coastal regions in Kenya. Again, really focused on the intersections of drug use and sexual and mental health. And in Central Asia, we've just finished up a piece of work in Kyrgyzstan looking at new psychoactive substance use and HIV, the results and data and evidence of which are coming out now. So please do keep an eye out for that. And we can wrap up here. Next slide. All to say, much more evidence from our partners will be coming out in the next sort of 12 months, and we're really keen to share that in forums just like this. We'll also be looking next year at our next grant making strategy to take effect from 2026. So love to hear more and find out more about stimulant use in the intersections with HIV and gaps and opportunities. Thanks very much.
Thank you, Tom, for giving us a very rapid overview of EJAF's work in this area. So just lastly, we have a short video before closing. So if people can bear with us for about 10 minutes more. And we have a video from PEPFAR, William Miller, who's the Senior Technical Advisor for Key Populations.
Good morning, good afternoon, good evening. My name is William Miller. I'm a Senior Technical Advisor for Key Populations at the Bureau for Global Health, Security and Diplomacy, or GHSD. And I'd first like to thank the organizers of this webinar, the South-to-South Learning Network, and the GPC for inviting us to speak on this important topic. As you all are well aware, PEPFAR's 5-year strategy includes a focus on reducing HIV transmission risk and improving outcomes for key populations living with HIV. Key populations, including those who use stimulant drugs, experience heightened HIV transmission risks due to both drug use and related behaviors like unprotected sex and needle sharing. Some of the core interventions that PEPFAR supports and are aligned with the WHO guidance to reduce HIV risks include condom distribution, HIV testing, antiretroviral therapy, psychosocial support, targeted education, and overdose prevention. Tailoring these interventions to meet the specific needs within different regions and subgroups is critical for their effectiveness. Ensuring that key populations have access to psychosocial support, such as psychologists and social workers, as part of HIV programs will help key populations in taking up and adhering to HIV prevention interventions and treatment by addressing mental health, harmful substance use, stigma, discrimination, and violence. Within HIV testing interventions, social network testing strategies are helpful in and recommended among intersectional KP groups such as PWID stimulants to reach more people in need of HIV services through social and sexual network referrals for testing. In the realm of harm reduction and stigma reduction, stigma related to drug use or sexual behaviors can prevent people from seeking care. Additionally, harm reduction strategies are needed to prevent HIV transmission and emphasize creating supportive environments to combat discrimination, especially for vulnerable groups. PEPFAR supports harm reduction, such as opioid agonist maintenance therapy and commodities for HIV prevention, motivational interviewing, and treatment, if needed, for people who inject drugs and others at risk who use stimulants. Community involvement is critical to effective program design. By including people who use drugs and those living with HIV in the design and implementation of programs, policymakers can foster trust and improve the reach and relevance of prevention efforts. Effective strategies often involve peer outreach, which can provide culturally sensitive support to at-risk groups in environments they trust. In the area of monitoring, generally, PEPFAR supports surveillance among drug users and PWID and other KP through biobehavioral surveys and monitoring of drug use through individual level client information systems and rapid coverage surveys, which can be useful in understanding the shifts in drug use over time and geographies, as well as intersectional risks among the underlying population or program clients. As an example, PEPFAR has supported efforts to better understand the unique populations of PWID and key populations who use stimulants and associated HIV risks through qualitative research, where the PEPFAR country team is considering the following follow-up interventions. First, developing a training module for community staff on synthetic drug use and the needs for people who use drugs and counseling for people who use drugs. Second, conducting trainings for PEPFAR-supported CBOs or community-based organizations. And third, engaging community-based organizations to develop behavior change and harm reduction communication products for synthetic drug users. In closing, I'd just like to say that PEPFAR remains committed to supporting key populations to reduce HIV incidence and improve outcomes along the HIV cascade by increasing access to comprehensive HIV services, including prevention, care, and treatment tailored to the specific needs of key populations. Thank you.
So just in closing, as we've heard from a range of UN agencies, donor agencies, civil society, and also communities, I think some of the key insights, lessons learned that will, hopefully shape future actions. One, we really started with the data on drug use, including on people who use stimulant drugs. I think a key thing that came out was really, the high numbers of people who do use drugs. And I think it's really important to, normalize a lot of this drug use. And really thanks to ICOM as well for also showing, how, people use drugs to really, it really does help facilitate people's work and lifestyle. There are reasons kind of behind it. We really do need this accurate data and a more fuller picture of why people use drugs to be able to design appropriate interventions. It really does start from that data and understanding. But unfortunately, as many of the speakers also mentioned, accurate data and information is currently very much hampered by the barriers experienced. We heard, for example, from NCOSA about the difficulty in obtaining accurate overdose data, which is absolutely key to saving lives. So in terms of the barriers, it was mentioned at the very beginning by Monica. and also Annette. A key barrier is the criminalization of drug use and possession, which drives a lot of the stigma and discrimination. It also leads to, low coverage of services that we currently experience. And, people are really driven away from services because of a fear of arrest, detention, and violence. For those who've joined, the other communities of practices before, we know that this has been a topic in the past. And, this topic really covered the impact of criminalization across key populations. A few people already mentioned about the importance of recognizing and addressing intersectionality. We really do support and really push for decriminalization, not only of drug use and possession, but also of sexual orientation and gender identity, and sex work. Third, as we heard from many of the speakers, there is guidance out there, including from WHO and UNODC, but there's real need to get this guidance to, influence what's happening on the ground. We really need, the push for implementation of this really important guidance. There needs to be more trainings, and for trainings, of course, to happen, there needs to be, the funding and the support behind it. For program managers and implementers on the call, I think, there was a really rich information given on what programs are out there for stimulant users. There was a very diverse range, it not only covers existing medications or treatment and health services, but also a range of, psychosocial services and other social services as well, such as housing, which was shared by Mainline, and the importance of housing, as a harm reduction tool. So we really need this whole of person approach. Several of the speakers also talked about the critical importance of community involvement, and coming from Input's perspective, also want to push, for this community involvement to happen. There really needs to be, of course, like funding behind it as well. So just in closing, we know that people don't have to experience harms from drug use. There doesn't have to be, mortality. We know how to prevent deaths and communicable diseases. And it's really about how we can gather the political will to find ways to fund and provide safe interventions and materials for all. So thank you, everyone, for staying a bit over time. I do want to thank the co-organizers again, particularly SSLN team, for bringing us all together, and the presenters for all their very rich information, all the work that they do, and to the audience for joining as well. So I hope everyone has a good, we're almost close to the end of the year. Thank you for joining.
Thanks.